Okay, let's finish up by talking about obstetrics. Obstetrics involves all of the anatomy we've previously discussed, but it relates solely to the process of pregnancy and birth. Know that most often the process of birth requires little medical intervention. However, occasionally there are complications present, and they are most often discovered prior to the event of childbirth. In the event a medical emergency occurs during labor, during birth, or in the early postpartum hours, it will be necessary for the surgical technologist to think and act quickly because the lives of mom and baby often depend on it. You will remember from a previous lecture video that a fertilized ovum implants into the endometrial layer of the uterus. The placenta is an organ that adheres to the endometrial layer of the uterus during pregnancy. Nutrients pass from the mother to the fetus during development through the placenta. Your Prep U assignment this time around includes both the female and male reproductive systems, and although this assignment is not due until your genitourinary unit, I urge you to complete all the items pertaining to female reproduction now because it is very beneficial to you. On the side nearer to the growing baby, the umbilical cord attaches to the baby and provides blood circulation while in utero. Knowing average gestation for humans is important when faced with patients who do not reach term or surpass it and the complications it could present. A normal delivery occurs vaginally without medical intervention. The cervix responds to the presence of the baby's head, and through uterine contractions, it dilates and effaces, and this allows the baby to be born. Occasionally, the mother's perineal tissue may tear, or the delivering physician may perform an episiotomy, which is an incision into the perineum to help prevent further tearing of the tissue during delivery and to give the fetus a little more room through which they are delivered. Depending on the grade of the laceration or episiotomy, it may need to be repaired immediately after birth by the physician. The scrub tech will be required to pass instruments and suture to the physician during this phase of the delivery. Know that obstetrical complications can occur at any time. That is why the healthcare team is always prepared for anything. These complications can be purely obstetrical or could be surgical complications. We will cover 7 complications that range from common to rare in our typical patient population. The first is placental abruption. This is a complication where the placenta detaches from the uterine wall prior to the delivery of the baby. This can occur after 20 weeks gestation and is categorized as partial or complete. In the event that a complete placental abruption has occurred, the life of the fetus is compromised, and depending on gestation, an emergency cesarean section will be performed. Viability of a fetus is the medical term used to describe the potential of a baby that is born prematurely. Currently, mothers that reach a gestational age of 24 weeks have the potential to have a baby be delivered, and that baby may survive. However, any gestational age prior to 24 weeks is not survivable if delivered prematurely. Placenta previa is diagnosed if the placenta implants itself partially or completely over the internal cervical os. Complications arrive if the mother begins laboring and the placenta separates when the cervix begins to dilate and efface. This can result in life-threatening hemorrhaging. Often, this condition is diagnosed prior to delivery and can be avoided with a scheduled C-section prior to the mother beginning labor. Another fairly common obstetrical complication is pregnancy-induced hypertension or high blood pressure. These cases can be mild or very severe, And obviously, it's the severe cases that we will concern ourselves with as it pertains to our role as the ST. In the event a mother is diagnosed with PIH and becomes eclamptic, they are at risk for seizures. Should seizures occur, the ST should anticipate an emergency C-section for the mother and baby's safety. A nuchal cord is when the umbilical cord is wrapped around the baby's neck at least once while in utero. It is rarely diagnosed because it is difficult to see on ultrasound. It is suspected if the heart rate of the baby drops significantly during a mother's contraction. In the event the baby's heart rate does not recover appropriately, or suspected delivery is still hours away, a C-section may be necessary and anticipated by the scrub tech. Cord prolapse is diagnosed in the event the amniotic sac is ruptured. Amniotic sacs can rupture naturally, aka my water broke, or artificially, when a physician can go in vaginally and break the bag of waters. When the amniotic sac is ruptured, it's possible that the umbilical cord could travel through the cervical os and into the vagina and even out of the body ahead of the baby. This can be life-threatening to the baby because the umbilical cord holds the oxygen and blood supply for the baby. Should a cord prolapse occur, an emergency C-section is imminent, and time is so crucial. This particular condition hits me close to home, as I have a cousin who experienced this while pregnant with twins. She became eclamptic when she was 30 weeks along, and she was hospitalized, and 30 weeks was considered too early to deliver, especially with twins. So she waited patiently as the days slowly passed by. At some point, the time is not known absolutely, her water had broke. Because she was unaware of this event, she was not anticipating any major excitement for the day. Upon using her private restroom, she discovered one of the baby's umbilical cords had slipped through the cervix and had become strangulated. My cousin was rushed into surgery, and only one of her little girls survived. I don't tell you this story to make you sad, as the particular events in this story were completely unpredictable. But I tell you it because it's so important for you to know these conditions so that you don't have to look them up if and when one of them is discovered. Breech presentation is when the baby is positioned in the uterus any way but head down. This can potentially be a complication as it can make the labor process longer and more difficult, which fatigues the mother and adds stress to the baby. Often, breech presentation is discovered in the final weeks leading up to the mother's due date, and there are techniques available that may reposition the fetus. Should a mother be scheduled for a version in which the OB physician attempts to rotate the fetus in the hospital, it is common practice for an ST to be on standby, as there is a chance that manipulation can stress the baby and a C-section may be immediately required. Additionally, a C-section could be recommended to a mother laboring with a breech baby because of the aforementioned reasons due to obstetrical emergency. Lack of progression is another common obstetrical complication in which the process of labor stalls, or it is determined that the baby's presentation or head may not pass through the mother's pelvis. This situation is handled differently by each OB physician, but it is likely a C-section will be required in the event labor has slowed, if it's become ineffective, or in more extreme situations, the mother cannot effectively push the baby out. That's it. That's all I have for you for this unit. When you come to class this week, we'll have some in-class discussion. We will learn and handle the GYN instrumentation we own, and you'll have time to work on your homework. I'll see you then.